Welcome to Global Health Dialogues, the podcast where we bring together the boldest voices and the brightest minds shaping the future of health equity around the world. I'm your host, Princess Dina Mired. Today, we delve into the urgent challenge of delivering equitable cancer care in cities across low and middle-income countries. Our guest is a global changemaker whose leadership is transforming how we build resilient cancer care systems from the ground up. Joining me is Isabel Mestres, CEO of the City Cancer Challenge Foundation, abbreviated as CCAN, a pioneering initiative that empowers cities to design and implement sustainable cancer solutions. From her work at the International Union for Cancer Control, UICC, to now leading CCAN, Isabel has been at the forefront of redefining collaboration, partnerships, and innovation in global cancer care. I have known Isabel now for more than 14 years, since my earliest involvement with UICC, and have witnessed more closely her work ethic and brilliance when I became president-elect of UICC in 2016, and especially when we traveled together to 3 City Cancer Challenge cities, Cali, Asunción, and Porto Alegre. I have to tell you, she utilized my time 200%, literally from beginning to end, from me landing till leaving to the airport. Unbelievable and amazing. Together, we hope to explore what it takes to move from global ambition to local action, and how cities, as engines of change, can become the front line of hope for cancer patients everywhere. Isabel, your journey into global health and leadership is quite unique. Can you share what led you to work in this space and eventually to lead CCAN?
Thank you so much, Princess Dina. It's an honor to be here today and humbled also. And I really appreciate your comment around my work ethics. I really appreciate that. That's something very important for me. So with that, how do I end up here? I think global health found me. I didn't look for global health. I studied business in school. And back then, the options were very limited. We're always about marketing, financing, big consultancy companies. And I started my career in marketing in Procter & Gamble, Nestle. But I was not happy. I was really not very motivated to wake up and start selling shampoos. And there was always something missing in life. And I was trying to fill those gaps, supporting local charities. That's where I felt fulfilled. But I never thought I could do that as part of my career. And that after I had a bit of a crisis of identity and finding my place in life, that's what I decided, that actually I want to do this for a living. That's what makes me happy and makes me proud with myself. And then I joined UICC. I had an opportunity to break into this space and bring in my experience in business development. I was very new. That was in 2009. And I fall in love. I was just so happy. I wake up for the last 15 years with a smile to go to work. The problem is when I stop. And at UICC, I started learning everything. I didn't know anything. And I learned about cancer. I learned about health systems. I learned about global health, development space. And in that journey, with my ambition of greatest impact, that's when CCAN crossed my path. It was an idea from UICC to support low and middle-income countries to strengthen cancer care. And I just thought that was what I wanted to do. And then I put all my efforts to transform that idea into a reality. Back then, you were part of that journey. And then I've been working really hard to make CCAN a reality. And the last 3 years, I became CEO. And I really enjoy it. And I have to say that it was an external recruitment process. I always want to say that. I had to fight for that position, despite me being part of the founding team of CCAN.
Well, I was so happy when you were chosen as CEO. Again, because I know about your work ethic and I know, and it's very difficult to say no to you. And to have someone like you with a business mindset is so important because actually, I believe a lot of what global health systems suffer from is the fact that we don't utilize business work models or tools enough in fixing health issues. And so, I'm so glad you became the CEO of CCAM. Isabel, can you please explain to our listeners in layman terms what is the City Cancer Challenge model and what it aims to achieve and how it works?
So City Cancer Challenge, the objective is to support low and middle income countries to improve access to cancer care. That's what we're trying to do. The key thing is how. How are we doing it? It's actually working from the ground up. Health systems are complex and require a full approach. Traditionally in development space, it has been very silos approach because of the complexity. So there's been screening, and I know you're familiar with that. You run a screening campaign, and then you find the potential patients, and then what if there is no service available, if there is no pathway? So we need to go from a systemic approach. So what City Cancer Challenge that is works with cities, that in a city you can see the whole system. You can see the primary, the secondary, the tertiary, the public, the private, the university, and actually you can coordinate a locally led response. And what that means is that we bring all the stakeholders together from all the different environments, and then we work with them to generate the data to understand what are the gaps, and we work with them to find contextualized solutions that were in their context, and we work with them to implement them. And that's always through technical cooperation and capacity development. So that's, in a nutshell, what CCAN does. So it's full system, locally led, and then we scale up to the national level those solutions that have worked in that context.
Isabel, I think I just want to unpack something for our listeners because you brushed so briefly about it, but I think it's the most important thing, which is the fact that you've assembled an executive city committee, a city executive committee on the ground, so that it can become the engine for moving forward all your cancer plans. Like you said, from getting the data to putting the strategy to put the action plan. And I think from my own experience, whether when I was Director General of the King Hussein Cancer Foundation and later on what I have seen when I was president of UICC, governance and local ownership were big issues in countries all over the world. And so when you talk about that you've assembled an inclusive committee across all the landscape of cancer care at a city level, this is huge. Because if you remember when I visited you in the 3 cities, Cali, Asunción, and Porto Alegre, and remember when I would meet the executive committee that you've assembled, that was totally in the beginning of the City Cancer Challenge initiative, when we were first trying to convince people to believe in the program and to join it. I remember asking the City Executive Committee, I think it was in Asunción, when was the last time you've seen each other? And I remember no one put their hand up. So that told you a lot, how much disjointedness there was and how much there was no focal point on the ground that's really carrying the cancer fight. So I think this is one of the main, I would say, success of City Cancer Challenge, is that you've created the managerial infrastructure and engine on the ground that is going to move things forward. So I just wanted to tell our viewers how important that is. So the other thing, of course, is the fact that you mentioned about local ownership. They are the ones who are going to tell you about the context on the ground. It's all very well to have theory, but the people on the ground, the ones who are living the consequences of the gaps of cancer care. They are the ones who are going to tell you not only the challenges, but also the solutions.
Exactly.
So, yeah.
Yeah, so this is one of the, I would say, the core or most important piece of our process. Our model is a step-by-step process. And of course, it starts with the city application. And that's where we see the political commitment. When a city applies, the government, the national and the region, the local government have to be part of that process together with civil society. And that's when we start sparking political commitment. Then if they're ready, we go in. And then the stakeholder engagement phase, which is what you're talking about, which is start mapping who is who in that territory that makes any decision that has to do with cancer care, that being reimbursement, financial, that be health workforce development, that could be the data generation, that could be the services, the diagnostics, the primary, the secondary level, who are all those actors. And then once we do a full mapping, normally it's an intense mapping exercise, then we come up with the decision makers and we create what you call in the city executive committee. It's a really hard exercise because that's not something they're used to. Normally in these countries, it's a top-down approach coming from the national government. The challenge they're facing is that they have very fragmented system and there is no data. So the plans are not backed up with realities. The plans are backed up with guidance from the international community where the evidence available is on high-income country settings. So what works for a country like Switzerland with a 10,000 annual budget doesn't work in Nairobi or Kenya with a $40 annual budget. So we need to start integrating and understanding those contexts and what is feasible to improve those systems. So we need to bring the people in the ground. You said it, the people that are actually every day seeing what are the challenges those patients are suffering. And the system is so fragmented and they don't talk between each other. The private doesn't speak, of course, with the private sector. But even between primary, secondary, they don't talk. So what that means is that patients are lost in the system and they're not lost inside one institution. They're lost outside because they go from one institution to another one. And they're like going with their papers from one go and papers are not valid in all the institutions. So it's a bit of a stressful situation for patients. And that is what we're trying to actually bring through the leadership, show that they have to be united and they have to come up with a united solution that brings value for the patients. Because sometimes, and this is one of the biggest challenges, is how we manage conflict of interest. Not conflict of interest, but personal interests. Sometimes all the institutions are looking, what is it for me? And we need to start putting the mind into what is it for the patient. And I've been in situations, where the private sector said, yeah, but if I join, are you going to improve the public sector? So am I going to lose patients? And I'm like, really? I mean, there's so many patients that with the current services, you're going to have always clients. But we have to make sure that everybody has access and we overcome those. So there's a lot of work on changing the mindset. And it's part of understanding, it's about leadership skills. When you are in a company and you start thinking about your own team and you talk about, because marketing, instead of thinking, what is the vision of the organization? And you see that the leaders are the ones that are not thinking on their team, they're thinking of the organization. So when we crack these people to start thinking collectively, that's when we find champions in the city. And those are the ones that actually start moving SICAN ahead. So we need a lot of clicking into a collective impact mindset. And it's possible. And it's a lot of coffees.
Yes.
A lot of corridor talks.
How long does it take? How long does it take to assemble, first of all?
Assemble is easy because there is the fear of missing out.
Yes.
So everybody's in,
Yes.
What is difficult is the maintenance of that group, the commitment, and clicking that the collective value is better than the individual value and that they will grow as an individuals if they go for the collective impact. And once they see that they access, the environment is improving, therefore their institution, their role is improving, then the magic happens. And that takes to assemble, to get everybody on the same page, understand SICAN, 3 months. But then the stakeholder engagement is a monthly exercise. And that's when things go up and down. And that's where I come in. We need to boost motivation or another team member goes to build value for them. It's a lot of value generation and understanding what moves people.
So, Isabel, thank you for, telling us that it requires psychology, therapy, motivation to actually make people believe that the collective motivation and goals are better for each individual institution. And I can really appreciate how hard this is. But like you said, once you show value and mini successes, even, people will stay on course. But I wanted to ask you, what does that mean for your team? How do you organize your team? How do you go about then once you have the data, how do you move across from the data to strategy to action planning? I remember once you told me that in one executive committee meeting, everybody was so excited. They wanted to fix everything. And when you wanted to whittle down the action plan or the priorities, shall we say, to few items per year, they wanted to put like everything in the first year. So can you give us a flavor of, what it takes and how does it happen on the ground?
So once they're motivated and they believe on this step-by-step model and everything we're going to be doing, they want to accelerate to implementation. Them and everybody, donors, are pushing us to go to implementation, but things need to be done properly so that we are looking for sustainable and lasting impact. So that means data. Also data, they want to skip data because everybody knows what are their own challenges. But we need the data, the systemic data, so that we all have a common understanding, and it's about the system and it's not about their perspective. So data is part also of this common sense. So once we have the data is collected normally around, it covers 80% of all the institutions that serve that population, both night and day populations. And then we create groups. There's 4 main groups. One that is doing diagnostic, another one is doing treatment, another one is doing quality, and another one is doing access, which is where we bring the patients also into this exercise. And then imagine subgroups. So there is the pathology group. So the pathologists from the main institution become a group, a working group. Public, private, military, whatever services. Same with the surgeons, same with the oncologists, same with the palliative care, same with the nurses. All the different specialties create subgroups. All of those subgroups analyze the data and they come up with a roadmap to improve the situation on their specialty. And then it's a really nice way because it starts building communities of practice and they start building the connectivity and they start thinking of the system not on their own institution. There's always like, we need PET scan. Or I need it in my institution. And no, I need it in my institution. Well, funding is limited. So let's see what is the best place to ensure quality maintenance and accessibility to the patients. And that's the mind when they're looking about imaging diagnostics. So that's, imagine we have like between 50 and 25 working teams, and then they present to the executive committee their recommendations. And then that's where the technical cooperation team and all our partners come in. So that's when we bring WHO, the Atomic Energy Agency, ASCO, ESMO, all the different organizations to guide the city on international standards, because the decision is of the local stakeholders. We just bring support when it's needed to accelerate. And then they go through, once they come up with a strategic plan for the city, there's, as you say, 100 issues, 100 priorities. And then we do a prioritization and say, based on this roadmap for the city, which is already a product per se, an output, you have a 10-year plan for the city across all the disciplines. Now let's go for what are the priorities. And then we choose between 10, 12 priorities, which is a lot, but it's hard to go lower with all the pressure from the city. And those priorities, I have to say, they're not sexy to donors because we're not jumping to set up AI. We're not jumping to set up, advanced diagnostic. We're going to set up the fundamentals of cancer care, the pillars of the building. So it's about standards of care. It's about quality assurance program. It's about pathways for patients. It's about, the projects that are needed to have products for investment is the basis of the system. The type of projects that come out, I always say they're not sexy for donors because they're not the shiny things that to open a new hospital or a new machine or a very sophisticated AI solution. No, we're talking about fundamentals, understanding what are the guidelines and protocols, the standards of care, the safety nets, the workforce development, the basic data infrastructure. And that's what we're doing, setting up the first layers to ensure that the city has a standardized care across all the facilities and quality sets. The quality is one of the biggest challenges, and that's what we need to start to make sure that there is standards of care across all the different institutions in that city. One of the biggest challenges is quality, and make sure that regardless of where the patient arrives, in which hospital, primary health care institution, that there is the basic quality and the standard of care across all of them, so everybody has the same access and quality regardless of their starting point in the system.
Yeah.
So that's why that standardization of care is the first cycle of projects to make sure that the whole city is at the same level and can guarantee quality of care.
But I want to pick up on something that you said. Actually, when you talk about quality of care, in the health world, quality is not some luxury item. It is really about life and death. It's about safety, right? Especially with cancer. If you have, there is no mediocrity in cancer care. You either have the top cancer care program or or don't have it. So quality certainly is key. And I also want to unpack something else. You mentioned about donors, the fact that, they're also a big part of City Cancer Challenge. And how have you managed to navigate them to work on that one plan, like you said? Because they also have their pressures. They want their shiny projects. They want the PR. And really, this is not what is required at that point, because we know many low middle income countries, like you said, the context from where you are starting is, especially with regards to the infrastructure of cancer care, is so basic. Why? Because the global health, has delayed helping those countries to lay the ground for building the infrastructure for cancer care, because prior to 2011, they decided for some reason that low middle income countries are only busy with the infectious diseases. And so all the money and all the support only went for that. And that's why there's so much delay for many low middle income countries. And they literally don't have the first level of the foundation for building upon cancer care. So how have you managed to get donors to really follow the line, look at that one plan, don't come in just with their own agenda of what they want to do and what feels, like you said, sexy to them, but actually look at the one plan and see where the gap is and say, you know what, I can fill in this gap. Another donor can say, I can fill in this gap. Have you managed to organize that and make them, join the same thinking and vision?
So, Princess Dina, actually, that is the most difficult thing, is to combine the local needs with the donors' and expectations. Sadly, they don't match. I remember actually now once you had a presentation when people were asking, you remember, lemons, and the community was launching oranges. So that illustration you once made that made me laugh, it's real. It's just like we're not aligning needs with the response of the global community. One of the biggest challenges also is the fact that we come from a very heavy communicable disease perspective from the donors. And then, that brings that there has been massive focus on prevention and primary healthcare, but the system per se has been actually neglected. And now we see the weakness of those systems. And I think that while SICAN comes with the cancer lens, what we're actually doing is health system strengthening from the most complex of the disease. So it's hard. It's hard to convince donors to think on the long term, because what we're doing is health system strengthening, and this doesn't happen like that. It's not like number of vaccines, number of kids prevented. And that also, that measurement is actually something that is challenging for the NCD and cancer community, because it's not, how many people screened or women screened. That doesn't go into life saves. Actually, if you're just thinking of screening, which is one of the most things that donors insist on doing, because you have number of women screened and number of suspicious, what actually I'm seeing in our cities is that most of these women with suspicious get lost in the system and they don't get any confirmation. And we're working really hard to bring sure that those women have a next step in that journey. But the donors only invest on the screening. So there's a lot of money lost in this perspective. And how I do it is just trying to get them see the long-term picture. And if you think about them, by strengthening those systems, it's a win-win. And if you think about the private sector, to be honest, it's a win-win. I mean, I want them to sell medicine. I want those medicines to the patients. So how do we help me to strengthen the system so actually that environment can guarantee the right medicine to the right patient at the right time? And that's what we need to focus on, what brings together. But it's not easy. And again, we struggle to find funding outside the private sector.
Yes. And I want to add to what you said from my own personal experience when I was Director General of the King Hussein Cancer Foundation. And you probably heard it before, but for our listeners, I remember, when we first started, we prioritized what we wanted to do as a team for the King Hussein Cancer Center. And we wanted to focus on fixing the quality of treatment. And I remember some big NGO that works in the breast cancer space. They, with good intentions, of course, they came and said, we want to help you start screening for breast cancer. And I remember we told them very quickly, and we said, no, thank you. And I remember they were shocked. I remember seeing their pupils open up in shock. What do you mean? We're here to help you do screening for breast cancer, which you don't have. And we said, we're very sorry. This is not our priority right now, because there's also timing for things. Why would we tell a woman that she has breast cancer when we haven't yet fixed the treatment for breast cancer? Why let this woman worry that she has breast cancer many years before when there's nothing down the line to help her? And that's what we did. And sure enough, when we fixed the treatment, the quality of the treatment, that's when we started the Jordan Breast Cancer Program, which is one of the most successful breast cancer program for the country to this day. So what you said is absolutely true. And I sincerely hope that many donors who are listening to this podcast, please think of the big picture. Think of the end result. It's about the patients, about helping them actually survive this deadly disease. And like Isabel said, that it's a win-win. Once you have the system going, the strengthening, all the navigation, the connections of the system worked out, you will have many more patients to sell medicines to support, and so on. Everybody wins at the end. So this was actually a very important point that you brought about.
Yeah, it's that we have to see it as the whole journey of a patient. We cannot think it's a single step, because if not, all the investments are broken. And I think you said something like, I understand that donors are not going to support everything. I mean, that's ideal, no? Support the whole ecosystem. But what I can do is combine. Okay, so you can support workforce development and give me the flexibility. You support clinical guidance, you support palliative care, and then all combined, I can make it happen. But even still, it's a puzzle that is hard, because let's face it, one of the things that affects me personally the most is palliative care. Palliative care is the most underfunded thing. And I think it's a dignity aspect for these people, that they are dying unnecessarily because they are they're not living on a high income setting, and they're dying unnecessarily of cancer, not because of cancer, but because the system is not ready. And while despite dying, they're dying with unbearable pain. And that's one of my biggest challenges to fundraise. And then people say, oh, we have to be patient-centric. Well, patient-centric, if you ask a patient what's the biggest fear, is pain.
Yeah, absolutely, Isabel. I mean, and especially for the fact, because of lack of cancer care in low middle income countries, 70% of patients are dying. So the least we could do is, like you said, help them to pass away peacefully.
Exactly. Something that is affordable. It's not expensive.
And it's not expensive. It's actually, many of the obstacles of palliative care is actually bureaucratic, because the cost of morphine is affordable. It's actually the bureaucratic side that is challenging. And unfortunately, not so many governments are willing to fix these bureaucratic glitches to actually help support patients.
Yeah. And now that we're talking about the government, this is another thing. It's the time of the project. So second, to see output, we need 3 years. To see outcomes, so actual reduction on time from diagnostic to treatment or reduction of abandonment rates, you need at least 10 years. It takes time. And, there is no patience from anybody. There is no patience from the donors. There's no patience from the government that there is a quick turnaround. And this understanding that it's a long game, it's a lot of the work that I try to explain, that this is a long game and we need everybody to understand and think in long term. And so we manage a lot, and this is something you were very, very helpful, which is political transitions. You remember one of the exercises we did in Paraguay together, there was these political elections, the presidential elections. So it was about, when I will call you Princess Dina, help us. We need to meet the candidates, because when they're candidates, everything is very nice. They're a lot very open. So I remember how great when we went together and actually start meeting all the candidates. So when there is a presidential change, SICAN remains valid. And it's sustainable per se, because it's about the community who's driving. It's not the political, but it's super important to have the political commitment, and that they think that this is not about the last government. It's not. This is about the community, and they're just building on what the others have done before.
Well, I think also, Isabel, if you remember, I think it was in Asunción in Paraguay, when we went to meet the Senate. And I think there's a lot to say about communicating to all influencers of cancer care in the city, in the country. And I think that's what I loved about SICAN, is the fact that your executive committee at the city level, it doesn't just include only the technical people, the pathologists, the oncologists, the nursing, etc., but it also includes the influencers in that country, whoever they may be, anybody who has pull, anybody who has connections. And there is value in communicating about SICAN. Why is it important for people? And I remember when I went with you to the Senate at that time, they did not know about the City Cancer Challenge effort that's starting in their own country. And if you recall, they had even a law that they were going to, make into a law about cancer care without anybody from the cancer care community having even seen it, if you recall.
Yeah.
And when we explained to them the power of this initiative, and that they cannot ratify a law when nobody else from the cancer space or the health space has seen it, wait a bit, let the executive committee see the law, and then they will let you know what are the gaps in the law. Is it helpful? Is it going to be achievable? Is it logical, etc.? And then remember, they delayed the law and sent it back to the executive committee.
Yeah.
And a year later, we had the great news. Not only did they fix the law, the executive committee worked with them to fix the law, but also the government put a line item, remember, of 50 million, the first time ever in putting a line item for cancer care.
Yeah.
And so what I want to emphasize here is communication is also key. Exactly what you said. It's the health system nowadays is no longer of a doctor coming in a black bag delivering medication to a patient. It's the health system in its entirety, including, cold chain storage, including the politics, like you said, with palliative care. It's the politics that stops palliative care being implemented. So communicating, probably most of your work goes into communicating to every single actually influencer, whether good or bad, to explain to them why they need to be aligned on this. And, I have found, certainly in my experience when I was the director of King Hussein Cancer Foundation, explaining to people many times, actually, it worked. People are logical. People are, once they understand the value of things, I have to say 80% of the time it worked once you communicate and explain.
Yeah.
So that's a very important point that you brought.
Very important that illustrates when at the national level, which is the traditional way of approaching cancer care in the past, how they came up with this law, which was not consulted with the local stakeholders, with the people that are every day, facing these challenges, and it was not a good law. The draft was not good and not suited for the context. So you see that when you go down to the community level and then they work collectively on strengthening that law, then when that law passed actually has an impact because that law was based on the context of that community. And yes, of course, there were some money line. And that actually, one of the implications was it increased 700% the cost of the availability to pay for medicines. So the medicines increased 700% budget for medicines in the public hospital for oncology, which was massive. And again, that's the start, but it's not the end because the medicines are there, but the systems are not there.
Yes.
So then we had to start working on setting up the guidelines, setting up the multidisciplinary teams, following up the patient. We were seeing how, for example, we strengthened the lab, but maybe the samples were coming on bottles of Coca-Cola. So we had to upgrade the Tupperwares. We had to upgrade the flow of the samples so that there was no damages to the samples. We had to increase the turnaround time for the time of results. We had to turn. So there's been a lot of, micro changes that overall have speed the process of the patient to reach treatment, but also the quality. Now there is barcoding in the labs. There is eye contact so that only the person that is legitimate to go to the lab can go in the lab. There is proper management of the samples. It's incredible, the before and after in the journey that we've seen in Asunción. Because again, even the medicines, I always insist, it comes at the end of the journey, or almost at the end. There's so much that has to be made before, and we work on the whole journey of that patient. But I really want to tell the world that we've nailed a model. This ground up approach is so sustainable because it's led by them, it's for them in their context. And then when you elevate it national and it becomes a national policy, when it goes down, it gets implemented because it's actually what they needed.
Yes. And I think what you said about people think it's, great, we got medicines. That's exactly what we experience at the King Hussein Cancer Center, is that many people used to think, imagine, our context was so much better than other low middle income countries. Imagine, we had the building, we had the machinery.
Yeah.
Top machinery. We even have amazing healthcare workforce. Jordan is very well known, so many doctors and engineers we have in Jordan. And imagine, so our context was, ticked so many boxes. We had great labs, we had pathologists, you name it. And yet we couldn't deliver quality cancer care because you still have to connect the dots from everything. And our issue at that time was governance, actually. Our issue was really governance issues, a lack of strategy, lack of planning. Until we fix that, the sky was the limit, and now we became one of the top accredited cancer centers worldwide.
Yeah.
But so I can only imagine when you are working in cities where the context is so sparse of any kind of infrastructure, like you said, from actual samples in the pathology being transported in Coca-Cola bottles. So, how hard is that? And but I also think it's so amazing. That's what City Cancer Challenge is doing, is going on the ground, understanding the issues with the executive committee on the ground, and pushing for, everybody to be aligned so they connect the systems together. Because if the systems are disjointed, then the patient care is disjointed.
Also disjointed, exactly.
Yeah, and like you said, again, quality is key. And I've been a champion of City Cancer Challenge since the very
I'm
beginning.
curious to know, Princess Dina, I remember back then we had a lot of challenges. You remember, not everybody believed on the model, but you did. So what I always curious to ask you, what did you saw back then when actually it was just an idea, and I would say there was more people against than in favor?
Yeah. Well, I think, for our listeners who don't know, prior to me becoming the president of the Union for International Cancer Control in 2016, I was for 15 years prior the Director General of the King Hussein Cancer Foundation. So I was a CEO, part of the team at the King Hussein Cancer Foundation and Center, and we were working on the ground in Jordan in a low middle income country setting, trying to improve cancer care for the people of Jordan.
Yeah.
So when the initiative was being spoken of, the idea of, for the first time, UICC, when they first established the initiative, which later, of course, became independent as the City Cancer Challenge Foundation. But when the speaking about it started, of course, it made sense to me. It felt real. It felt logical, because it had one thing. It was, going on the ground, because nobody can understand what's going on the ground, the resistance, the challenges, etc. on the ground, unless you are willing to do that. So that was a big plus for me. Two, again, as I said before, the fact that City Cancer Challenge model is the fact that it really understood the importance of governance issues, and the fact that there needs to be a focal engine on the ground that includes everybody in the cancer care space that's going to move things around. So that was it rang a big bell for me, because that's exactly what was our issue here in Jordan. And at the same time, the fact that you appreciated local ownership, the fact that you would not go to a country or accept a city that the government gave the political will to engage with City Cancer Challenge Foundation, because without that, you can't really go very far. You need local ownership. And the fact that it was a long-term partnership. It's not one of those fly-by partnerships that I have seen during my tenure when I was at the King Hussein Cancer Foundation. It's those long-term partnerships that stay with you, that understand not only your challenges, but understand whether you are working hard and succeeding in ticking the boxes as you went along is very important. And that is why I believed in CCAN in the very beginning. And to say, really, if I wanted to summarize also, again, why CCAN is very special, is also because it really actually uses the tools of successful businesses, whether marketing, whether communication, whether strategy, whether action plan. The fact that you thinking about one plan for the city. I mean, this is a no-brainer in the business world. In a business setting, you don't have many plans people are working on. They have one goal and one plan. And so I was a big champion, and everybody at UICC used to know that, don't talk to Dina. She loves City Cancer Challenge. And that's why I actually traveled the world with you and came to visit 3 cities when I was president-elect and president. And later on, I visited Kumasi in Ghana to also connect people and give support and meeting with the political people to tell them that how important it was for them to embrace this initiative, and not only to embrace it, to make it easy for the initiative to work very well and to work quickly. And I remember telling the First Lady in Ghana, saying, had we had something like the City Cancer Challenge model when we first started doing our work here in Jordan to try to deliver quality cancer care, my goodness, I'm sure we would have moved so much more faster and with confidence to be able to do that.
I think you said with confidence is important, and I really like the business approach is true. I mean, my team doesn't like this, but I keep saying we're like a consultant, but with technical cooperation and capacity development behind. But, we bring the tools on leadership. We train leadership skills. We train program management. We train monitor evaluation. We train health financing. Like, not only the clinical skills, but also the business skills, so that they don't skip planning. So that, like, if they want to expand the unit, for example, in Cali, there was a project. They wanted to expand the public hospital and incorporate a cancer unit. Well, you need a plan and you need to cost it, because if not, who's going to invest on it? And actually, they developed the plan. We went to the national government, which actually was surprised because they don't get this level of planning. And then that means 15 million investment to actually create the cancer unit in that hospital. And once they see that those planning and those plans with costing and action and log frames with measurement and indicators is actually being translated in investment, then we get the momentum.
And did you get the money for that?
Yes.
And you got the money.
And exactly. We got the money. Another recent story around that is in Georgia. In Georgia, there is universal health coverage, which doesn't include diagnostic. Imagine how to get to treatment if you're not covering diagnostic. So again, we work with the local stakeholders, and with the support of experts, the locals come up with sort of the investment case for inclusion of diagnostic under UHC. It was a great work. And actually that meant last year, the government agreed on the inclusion of diagnostic under UHC. But that is, you need to bring the evidence and the efficiency around that and the cost effectiveness, and you need to talk their financial language. And that's where we have to bring that capacity and build the local capacity so they can do it. And again, it's not us going and do it and leaving, because that's not sustainable. That, as we say in Spain, there is bread for today, but hunger for tomorrow.
Yes, yes. And like you said, I love the idea of when you talked about you being, 24-hour consultants, because I remember telling that also to one of the leaders when I visited the cities with you, telling them, the City Cancer Challenge is giving you free consultancy. If you were ever to pay for it, you would be paying millions.
Yes.
So it's so true and so important. Now I really want to talk to the big elephant in the room. You've given me an example where you've costed something for 15 million and you got that investment. But sometimes the investments across all that cancer plan for 1 year, it's a lot of money. And we need to talk about, we really need to talk about the financing and long-term sustainability of that model, because I'm sure you've had cases where you've done the work, you've done the convincing and the value added of doing a plan, but then you didn't get the fund. How can CCAN ensure long-term sustainability and continued progress once the city has completed the initial phases of engagement?
That's the elephant in the room, and it's not, I don't have a great answer to that. I'm not going to say, great, we've nailed it. We haven't nailed it, and we're still learning. So we have different models that have worked and others that have not worked. To start, the first cohort of projects, the first cycle of projects are very much efficiency system, and they're not expensive. It's about understanding what are the gaps, generating the data, and reduce timing from diagnostic to treatment. That is manageable. Of course, when we're talking about big investment, infrastructure investment, that's when we have the biggest challenge, because GDPs are what they are. So we tend to focus on system efficiencies that are low investment, high impact. Being said, there is not yet great evidence on what are those best interventions. That's one of the biggest global gaps we have. There is evidence of intervention in high-income settings, but there's no evidence of interventions in low-income settings. And that's why part of my new strategy at SICK, when I jumped as CEO, was to start embedding implementation research, because we are doing it, but we were not bringing research protocols in our implementation activities. And that was a missed opportunity to tell the world what works and what doesn't work. So that's a new unit of SICK, which is implementation research, to generate and have more of a global impact, so that what we do in a city can show the world, okay, that worked, that didn't work. In terms of our model, how do we sustain our model? There's different ways. For example, in Cali, there is a local organization called Pro Pacifico, which is the union of many private sector that works very closely with the government, that has been doing a lot of development work in the past, but not in the area of cancer. So we actually convince them to actually take cancer as part of their portfolio. So they're organizations that actually are continuing SICK work, and they count with us to bring the network, the experts when they need, capacity development of fundraising. So we don't have financial investment. We bring the know-how, our tools, our assets, our partners, but they're the ones driving, and it's quite successful. And that was our first city. So we thought, perfect. That is not replicable everywhere. There's not always such an organization. So in Brazil, for example, there was patient organizations, great, like FEMAMA, led by Dr. Mayra Kalefi. But Mayra actually said, we don't have an organization with this capacity of actually driving implementation and health system strengthening. So the locals decided to set up sort of a local SICK version. And they set up a new organization, which, because there's funding in Brazil, which is well-funded locally, which actually continuing with our model based on their local needs, and we keep supporting them. I wish I could support them more, though, but there's always that financial constraint. And then there's other places where there's no one to take on. So in those cases, we're testing models. So in Georgia, our sustainability partner is the government. So the government is the one taking on those initiatives. So they have the projects, and they're committed to actually going and implementing the projects. It's one of our success stories in Georgia, and the government engagement with SICK, where the Tbilisi activities are becoming national activities. For example, one was the patients in Georgia went to the pharmacy, and they were during days going with all very expensive medicines around the city, and maybe they needed to be in the fridge, and the quality was lost. We didn't know what happened with those medicines from the pharmacy to the day of the treatment. So actually one of the projects was to set up pharmacies across all the hospitals, inside the hospital, so the patient didn't have to run away with these expensive medicines. And then the government took on, they drove the implementation, and they made it mandated and support all the hospitals to implement. That's a model that in some cases worked very well. And there's others where we don't have the government, we don't have a local organization, and we're still needed. So in those cases, we're staying longer, and we're going into multiple cycles of intervention. The problem here is that sometimes there's donors' interest, sometimes donors are not interested. So we're limited. And if a country wants to continue with our work, we need to have donor support.
Well, I remember many times you've asked me what was my experience when we led transformation care in Jordan, and especially with regards to long-term sustainability. And I would say for us, for sure, local government ownership. Governments have to put a line item for the cancer plan. There is no escaping that. Cancer care, if you want to fix it with the infrastructure, with the machinery, with whatever it is, human resources development, labs, etc., where people also, they don't have insurance cover for cancer payments are very much out of pocket. There is no escaping the responsibility of government to put a line item for cancer, whatever it is, from 50 million in 1 year to increasing it the next year or even less. It just won't work because, fixing cancer in a city or in a country, it costs millions. For one thing, at the time, our government was sending patients, sending them abroad to America, to Europe, spending millions and millions for the few. in a way, supporting those wasting money because they're, number one, it's not equitable. Number two, supporting those hospitals, in a way, giving them wonderful cash payments for foreign patients. So when we explain to them that we're going to deliver quality service, because quality, like you said, is key, and that they need to then, once we fix that, they need to send the Jordanian patients all, or them, as much as they can to the center. It's a win-win situation. They will save money, and it's a political gain because then it will be seen as equitable. Many more people will be able to get access to quality cancer care in Jordan. So having that, once we accredited the center, because we, from the beginning, quality was in mind, and the center went for putting quality protocols, and they went for accreditation. Once we got the accreditation for treatment, not only then the government then sent all patients to the King Hussein Cancer Center, so that brought money in lieu of treatment, in lieu of the millions that they were paying abroad to other hospitals abroad. Then it also helped, by the way, the accreditation helped to reverse the brain drain, and more trust from patients, even rich ones who can definitely afford to go to the top cancer centers elsewhere. They now believe they can come to the center, get the treatment here locally. And so that was key. So the sustainability came for, paying for treatment costs for patients on behalf of the government. But also, we also worked on donor and grassroots support. And we basically, I remember telling the team, we communicate to every single human being who has a heartbeat, telling them the story, telling them our vision about what we're going to do. And I remember people were saying, Jordan, it doesn't have the same GDP as Gulf countries. It's a low middle income country. And people are saying, you're not going to get enough money, the naysayers as usual. But actually, because our communication was so good, it was ongoing, what we're doing, how we're doing it, how clean we are, how transparent, and how we are focusing on quality and so on. We had so much support from the $1 to the hundreds of thousands. And also we worked on international and regional donors. And when they see also local ownership and we were very business-like. I always used to say the King Hussein Cancer Foundation is a business with a heart. We utilize all the top business tools to make things happen. And when donors saw that, they saw the professionalism and they saw the very, logical way that we were working. People like to join a successful
there's a strategic
wagon.
plan. There was a vision. So people
there was a vision,
were going.
and they wanted to support and be part of this success. And so working, having local government ownership, building a big donor base, local, regional, international, and actually delivering quality of service, really, that was our tools for sustainability. Role of government is so crucial. There is no way of escaping it. And for that, I wonder how many of your 15 cities you managed to get really good engagement on a government level.
That's something that we have improved. Because when we started, we were thinking about local governments. And in the first city, we quickly went to regional government and quickly went to national government. So, we don't work anywhere without a commitment of the national government, regional government, and local government. Because we've seen that actually without the national government, maybe we can do the planning, but we cannot do the implementation because many hospitals are under them, others not. So it's now we don't start anywhere without the national government. And actually, one of the cities we've struggled because it was not only the national government as the Ministry of Health, actually the president had to approve SICAN working in that country. And that was really, really tough because that's, there's some special rules around what type of organizations can work in a country and what not. And normally they're more limited to UN type of organizations. So sometimes we struggle with that. The mayor per se is somebody that we use more for communications, for engagement, for community engagement, and sometimes to sparkle, HPV vaccination, because that's something that the mayor can activate. In terms of the daily engagement, is more the regional government and the national government, not so much the city government that tends to be more focused on prevention activities and raising awareness on tobacco campaigns. So we tend to put the mayor in contact with other organizations that are very strong in prevention. But we have some success stories around, painting the government and the mayor to launch an HPV vaccination campaign, and that has been good. But it's not always easy. We do, as I said before, a lot of meetings with the government, because you need to keep them engaged and making sure that cancer remains a priority. But it is a priority, Princess Dina. It's the biggest killer in most of the countries. The second cause in Chile is the first cause of death. Maybe the global community doesn't see it, but the locals see that cancer is draining their system.
And looking across also your cities, which city you felt achieved milestones faster and why? And how do you find the success? Especially you work on many different contexts.
Yeah. Look, sometimes I used to get asked, which is your best city? And sorry, but this is like kids. I cannot say which kid is better than the other one. I love them all. But I've learned something myself. I got frustration with some cities, I have to say. Some cities were very slow and I get nervous. I'm impatient myself. But I realized that, some cultures have heritage and cultural heritage and other aspects that makes move different at different pace for different reasons. And maybe a small move in one city is equivalent to a big move in another city. None of them start at the same level. So sometimes there's a lot of work on mind shift, on changing the mindset, and that takes time. While others, you're right, the mindset is there and you just need to grow. Like Georgia has been, if you take in absolute numbers, Georgia, Tbilisi, it's incredible. Like, we've changed national policy, we've changed we've improved the quality across all the institutions. But others, it's actually starting from very, very low, and the move is very, very low. So now I start to appreciate some small moves in some contexts that come with a history, specifically countries with that's my impression, this is a personal opinion, countries with high history of development aid move in a slower pace than countries with lower history and development aids. And the localization agenda, or what we mean, the locals owning the power of change, of their own change, it's something we wanted always. And now maybe, with the current US government has been accelerated in the wrong way, but it's something that has to happen, because I'm seeing, for example, Latin America, that is not a historical recipient of the development space. They manage their way.
Yeah.
And progress happens more quickly.
Yeah. Yeah, I agree
know
with
what
you.
I mean?
Yes. I think if you keep thinking somebody else is going to fix your cancer center, your cancer care in your own country, they are dreaming. I always used to tell people, nobody is going to come and
Nobody's
build
going
you.
to sell. Yeah.
Nobody is going to go and build you the hospital. They're not going to come and buy you the machines. They're not going to. You can't sit passively waiting for things to happen. You have to be the one who owns it and organize the support how you see fit.
Yeah.
And I think that's what we did at KHCF, and this is what you are seeing.
Yeah.
And especially in line with what's happening now, where global aid is now doubtful, right? It's changing.
It's horrible, because it's definitely letting a lot of patients out, and I think but I think on the long term, if it could be seen as an opportunity to take ownership, because it was never going to be solved by others.
Yeah.
And if you're very involved yourself personally on childhood cancer, the community, it's amazing. It reflects the same. The childhood cancer community, the patient organizations, the pediatricians, the nurses that work in this space, they never get attention because they never get big funding support. But they've managed to be very creative, find their way. And that's why when you find somebody from the childhood cancer community, at least in oncology, they get things done.
Yeah. Yeah.
So while adults, it's a different beast, but it's the same. It's like when you have low resources, you find to be creative. And when it's just this, you need to own it. And we need to support these countries to own it.
Yes.
And I think that I like that about SICAN. And sometimes my team, we are sometimes worried because we're not 100% local. Let's face it. We want to be, but donors sometimes push us. And how we find the balance, that's always how I find the balance with donors' interest, with local interest. Sometimes I need to give up local interest for donors to actually cover local interests. And that balance is what I always need to find as 70% local, 30% donors, so that I can get extra funds to cover the underfunded.
Yes.
It's an art. Someday we will end up in local, 100% local needs. But
yes, you have... Since joining SICAN, how do you think how has the vision evolved since 2017?
It has.
On how you go about things. What key shifts have occurred over time, would you say?
So, massive. Because when we started, and Princess Dina, SICAN was a white page. We said we're going to work with cities, but we didn't know how. And that's when we went to Amman and to meet you and King Hussein. We needed inspiration on where do we start, because we didn't know. And that's where we were with our notebooks learning from all of you. And so we've gone through the first years of how do we work with cities and how do we do a systemic approach, because nobody has done that before on cancer care. And all the different, because it seemed impossible and complex, but we managed to put a step-by-step process. We managed to actually incorporate and know how to do stakeholder engagement. We learn and we build a model that works. Great. The initial thought was, you remember 200 cities?
Yes.
That thought was 200 cities. If you want to spark, mayor's interest like other initiatives, you're going to get mayor's interest and signed. But from interest and signing and having a press release to actually see changes in the system is a whole different thing. So we were naive, all of us. And that one of the shifts is no, we're not going to go to 200 cities. We're going to go to 20 cities and we're going to do it right. And what the other shift was that the SICAN was built in a 3-year model where we set up the ground, the basis, and then we hand it over. But then what we realized is that we were leaving the party at the best time. When everything, the basis was there and we could start seeing patient outcomes, we were leaving. And that's what I said, what type of organization we are. Our organization that set up the ground and move, or our organization that we want to tell the world what are those best interventions. And we want to bring evidence to the world. And that was the shift 3 years ago. And then the board agreed to go for a 10-year and actually go deep. So it was not just jumping from one city to another one. It's actually when we see a city that they're working, that they're performing, and that they're actually willing to continue, let's do multiple cycles of intervention. So now we have, for example, Kumasi, in Ghana, and Tbilisi, they're in cycle 2. Cycle 2 is more about service, infrastructure, the sexy things. But you cannot do the sexy things for donors if you don't do the first cycle and the stakeholder engagement and the data and the planning. So now the strategy is multiple cycles of intervention so that we can continue seeing until we actually see patient outcomes. Of course, the dream is, life saved. That's very long. But we have proxies now, and we've defined with the team and global experts from around the world indicators, which is another missing piece in the community. How do we measure success? So now we have, a set of 20 indicators, very basic, that we're able to start measuring improvements in the system. And that is something also that we're looking forward, have more data and publish that, because I think those indicators are going to be very helpful for the cancer community. So that's where we're going in, evidence, interventions that work that can be scaled in other, and deep in city and not butterflies city from city.
And final reflections, Isabel. I think the listeners have really understood that you are working in so many cities, different contexts, sparse infrastructure for cancer. And I'm not talking here about brick and mortar, about systems even in place and so on, and lack of financial resources. So it's a long, hard slog, like you said, balancing between donors and what's best for patients, balancing agendas, convincing people, how do you keep you and your team motivated? Can you share one story that made you think that it is worth a struggle?
Why don't we ask one of our donors who actually started with us from Icon Group? What do you think?
I think it's a great idea. Welcome to Global Health Dialogues, Mark. It has been a long time since I have seen you last. I think the last time I saw you when I visited the headquarters of Icon Group in Australia, I believe it was 2018 or so. For our listeners, Mark Middleton is the Group Chief Executive Officer and Executive Director of Icon Group, Australia's largest dedicated cancer care provider with 30 cancer centers across Australia. As a director of the inaugural City Cancer Challenge Board and as a co-chair of the Health Financing Advisory Committee at CCAN, not only have you been involved in the strategic direction of the initiative from the start, but you have also helped develop sustainable financing models for cancer care in urban settings, an area which Icon Group is an expert in. Mark, hearing from what we've discussed about CCAN, what made you decide that CCAN was the model you wanted to support? Could you talk about the projects that you have delivered and the journey you have taken with Isabel?
Well, firstly, thank you, Princess Dina. Lovely to see you again. Wonderful to be a guest on your podcast. Well, look, why did we decide to support CCAN? Yourself and Isabel are very persuasive, of course. Look, I grew up in regional Australia. Icon has had great success in taking cancer care to regional Australia. I feel a great affinity for those nations and those areas and those regions that don't have access to world-class cancer care. And I think we all know the complexities involved in delivering world-class cancer care in locations where it's never been delivered before, and indeed in countries where it's quite foreign to deliver cancer care in the way that perhaps we've become accustomed to. And I saw CCAN as an opportunity to turn the dial in particularly low and middle income countries, where we could apply expertise from countries like Australia, where we're very blessed to have a wonderful healthcare system and a wonderful oncology ecosystem. Why can't we take that knowledge and that capability and help others? And I saw CCAN as being an exceptional vehicle to do that. And I think the projects that Isabel and the team have delivered speak volumes. They have made a real impact. And these are the things we must keep doing, finding practical ways to deliver more care. We do a lot of talking about how we're going to help. I think what CCAN's managed to do is actually take those ideas and those concepts and then deliver them. And that's what has really inspired me about the CCAN journey.
And I agree with you. There's a lot of theories of about what should be done, but that's exactly what CCAN did. It's actually a courageous initiative, to say the least.
Absolutely.
The fact that they're taking the plunge into going on ground to do the real slog of working on the ground. But what have you done as Icon Group with Isabel, apart from being a board member and so on? What projects did you support?
Well, I think we've done a lot with Isabel, and we've had a great relationship with the CCAN team over many years now. And one of the things I'm incredibly proud of is what our nursing team has delivered. So our nursing team authored, created, and then delivered an oncology nursing syllabus to oncology nurses in Rwanda. Now, Icon, we don't have services in Rwanda. It's not a part of the world that we're active in. But we have a world-class nursing team who are able to take their skills across all of the Australian Icon centres. Now, of course, we're in Singapore, Malaysia, soon to be in Indonesia. We're in the United Kingdom. We have become expert in training people across that very broad network. So why can't we use all of those capabilities? And I must add, Princess Dina, some of those capabilities were thrust upon us by a global pandemic. We couldn't send people to train nurses at sites as we would have used to have done in a traditional sense. So we had to embrace innovation and technology to reach people where they are. And that's exactly how we've managed to deliver that training to a nursing workforce in Rwanda. Now, my team is incredibly proud of that, as am I. And I think, to be honest, Isabel, always interested in your thoughts, I think that was a groundbreaking piece of work. And it is something that can be replicated wherever Seek can go. So very, very proud of that.
This is so amazing. And for people who don't know, many, nurses are found all over the world, of course, but to have a qualified oncology nurse is another story. And the fact that you've given training to oncology nursing in Rwanda, I mean, that is beyond important and useful. Thank you, Mark, for your feedback on your work with CCAN. And I hope to see you again soon, maybe again in Australia, in Melbourne.
Well, Princess Dina, you are a great friend to ICON. You are always welcome to come and visit us. Our people still talk about your visit to our head office in Brisbane. So we would love to see you.
Thank you so much. Thank you.
Thank you, Mark.
So much.
Thank you. Lovely to see you both.
The team is very motivated because the team believes in the model highly. I mean, they're seeing the change and they believe so much in the model that they are all highly motivation and purpose-driven team. There are many stories. I guess what we like more is when the city manager, so our staff or team members in the ground, the ones that are convening, elevates in the biweekly meetings the local stories. When, for example, now we see that a hospital is now, meeting regularly in the multidisciplinary team for the first time. We celebrate that. When a guideline has been endorsed by a government, we're like, great. But when we see it implemented and the city manager, it's happening. Or when we see the first patients maybe like accessing, drugs that we have been reading the way for those treatments, we celebrate. We tend to celebrate small wins constantly. And every biweekly, we need to cheer what small step has done in one city in the other one. Of course, when we get the UICC coverage of diagnostic, we were all super happy. But it's more the small steps that we like to celebrate. Establishing an MDT, or suddenly, the nurses are now, all in the patient navigation. They're working on the digital tool. Well, when we get data of outputs, when we see that, for example, time from diagnostic has gone from 82 to 28, we are all very, very excited. But it's these little stories that it's hard to get it into these headlines that other organizations in that can have on numbers of vaccines. Us is those little stories that all add up, make that journey of a patient.
Well, that is so amazing. And you are so right. You're celebrating. It's not small steps. I wouldn't even call them small steps. It's moving forward in whatever form. And I know that CCAN, the fact that you've increased the support from 3 years to 10 years, you're going to see so much more. As I said, I love CCAN. I believe in it wholeheartedly. I'm always ready to be your ambassador. Actually, I'm always talking about City Cancer Challenge wherever I go, even when you don't ask me, because I truly believe that it is the model that's going to change things on the ground. I wish you all the luck. I'm always ready for you to support in any which way you see fit. And I know you are changing the lives of patients city by city all over the world. Thank you so much, Isabel, for joining me and in this Global Health Dialogues. And I'm sure all the listeners today enjoyed listening to you, and they got a really good feel about what the City Cancer Challenge Foundation model is all about and how it is the real deal, changing lives one step at a time. Thank you very much, Isabel, and hope to see you soon.
Thank you so much, Princess Dina, for being that ambassador for City Cancer Challenge for patients, because you're one of the biggest cancer advocates and the most passionate I've ever met. And also, thank you for championing me, for championing, woman to woman, how much you've cheered me in my development always. And I want to thank you. Thank you for being a sponsor, for not only a mentor, a sponsor, pushing me to my next level. So thank you for everything, Princess Dina.
You are amazing, Isabel. Thank you so much. And I'm honored also to be your friend.
Yes.
And I will always keep abreast of everything that you are doing.
Good.
Take care.
Thank you.
Thank you very much. Thank you.